welcome to our online webinar with Dr. Blaschke from New Zealand. My name is Holger Kast. I am Head of Training Education at Dental Implants, and today's topic is implantitis, diagnosis, therapy, and prevention, an evidence-based approach. And before I'm going to give the words to Dr. Blaschke, I would quickly like to introduce you in our soft tissue concept, because I think it's an indicator for really safe protection of peri-implantitis in our system. And you can see here on the left side, you can see the shape of our abutments. We have a consistent emergence profile in our abutments from healing color up to the final crown, which is basically here on the X-ray down there. You can see the shape of our abutments, which leads to more space for gingiva, which protect the bone surrounding the implant. And I think Dr. Blaschke is going to explain this in his presentation as well. And so the second very important thing is for prevention of peri-implantitis is the SBA surface in our system. The SBA surface is one-to-one the same as an SLA surface. It is an SLA surface with macrostructures from 20 to 40 micrometers and microstructures from 2 to 4 micrometers. And so this is also scientifically proven from the university in Cologne. And I think Dr. Blaschke is going to explain this white paper as well. And so then it's up. I want to give the word to Dr. Blaschke. Shortly, an introduction of Dr. Blaschke. Dr. Blaschke is practicing in New Zealand and also in Australia. He has a Master of Science of Oral Implantology made in the University in Frankfurt. And now I'm very happy to give the words to you, Dr. Blaschke. Go ahead with your presentation. I'm going to switch to your presentation. Hello. Hello.
Fantastic. Thank you for the lovely introduction. Do you get the screen?
Yes.
Now? Yeah.
1 second. Yes. Now you can share it.
Lovely. So you should have my screen now. Is that correct?
Yes.
Okay. Yes, okay, fantastic. So yeah, thanks for the lovely introduction. My name is Dr. Blaschke. I'm practicing in New Zealand as well as in Auckland as well as in Canberra in Australia. So I've got 2 practices, both limited to dental implants. This is the skyline of Auckland with the Sky Tower. My practice is right underneath here. That's where we're in Auckland. I don't have a photo of my practice in Canberra, unfortunately. But so that's where I'm sitting most of the time for the week. Today I would like to speak, as Mr. Kast, I have to find my mouse, sorry for that. Here we go. Today I would like to speak about peri-implantitis, diagnosis, therapy, and prevention. This is the first time I do a webinar, so please bear with my, it's quite unusual for me to not have feedback of a live audience. So a little bit of learning curve for me as well. If I'm too fast, Mr. Kast, please feel free to interrupt me to slow me a bit down. I promise not to tell any jokes because I have no idea if you're laughing anyway. So I think we will have 45 minutes of me talking to myself here. So it will be quite interesting to see what's happening. So again, I run 2 practices, both limited to oral implantology. Both are referral practices only. Let's get the ball rolling. I would like to cover a few topics, so just a bit of housekeeping. So I would like to talk. Where are we? I would like to talk about diagnosis and definition of peri-implantitis. So just to make sure that we know what you're talking about. I would like to talk about prevalence and trends in peri-implantitis because we see some shifts happening at the moment here. I will spend a few minutes talking about predisposition. Predisposition to peri-implantitis is close to my heart. We just finished a paper with the University of Frankfurt on the predisposition of peri-implantitis. This means how susceptible a patient is to peri-implantitis, and if we can screen our patients before we treat them to identify risk patients. I want to talk about implant-related factors. This is where the soft tissue concept of tree comes in. Obviously, we want to talk about treatment. I will pretty much keep that to the surgical treatment of peri-implantitis. Obviously, they are non-surgical concepts, but I will keep it to the surgical concepts as I find them more interesting. And we want to talk about prevention of peri-implantitis and what we can do to possibly prevent this from occurring. So let's get started with a definition. So peri-implantitis, at the end of the day, is of inflammatory origin. It's inflammation of the peri-implant tissue. Generally speaking, we have a peri-implant probing depth of at least 5 millimeters. That has changed slightly, but let's bear with me. We stick to 5 at this point. We want to see bleeding on probing or suppuration. Again, opinions are changing a little bit currently on that, but this is still the definition. We have bleeding on probing and or suppuration. We have a typical bony defect. Trying to get my mouse over here. So these are the typical bony defects we see in peri-implantitis. It's not a flat defect, it's a bowl-shaped defect. The implant, by definition, has to be in function. Again, this is a hot topic if it really has to be in function of peri-implantitis, but according to the current definition, it has to be in function. This is all based on the work of Mombelli. There are 2 papers, one a little bit older paper and a current paper, or more current paper. And currently, the definition has been changed to a probing depth of only 4 millimeters. So these are the changes in definition that we see happening. We're looking more critical at peri-implantitis. We're looking more critical at the tissue changes around implants. Whereas in the past, continuous bone loss was accepted. These were the criteria by Albrechtsen. Nowadays, it wouldn't be accepted anymore. So we look much more critical at our implants. So we got an example here. This is an old implant crown. That implant is quite a few years old. A patient came to me a couple of years ago with concerns on the implant. We see the probing depth is at least 5 millimeters, and we have bleeding on probing there, so that fits that criteria. Obviously, the implant's in function. And here's our radiological finding. So we get that bowl-shaped defect over here. Agreeable, this is an early peri-implantitis case. It has not really progressed very far yet. But as you will see, early treatment is one of the key factors of peri-implantitis. Here's another case. We treated that patient just a few days ago. That was, again, quite interesting. I will show that case later. This is a newer implant bridge, much newer. That was fabricated in London. The patient has moved to New Zealand since, so I inherited this patient. And we see the typical bone loss around this implant on the 2-1. And we see what potentially is a foreign body over here as well. So one could now presume this is cement from the bridge cementation. However, this bridge is in fact a screw-retained bridge. So there is no cement on that application and on that prosthesis. So at this point in time, I had no idea what we see here. My guess was as good as anyone else's guess. I will show that case later, and we will see that foreign body later in the case presentation. And one more, that is unfortunately one of my implants, and unfortunately it's a tree as well. I'm really sorry about that. Again, typical bone defect. However, according to the definition by Mobelli, this is not peri-implantitis because the implant is not in function. There is a healing abutment attached to it, but this is, again, a mistake by myself. We had a quite hectic day and patient came in for the uncovery, and I actually uncovered that implant without taking the implant before the uncovery. During the uncovery, I realized something was sort of not right, and then we took the X-ray. So this implant is not in function. However, my argument is it's still peri-implantitis, even if the implant is not in function. So let's look at trends, at prevalence of peri-implantitis. Prevalence meaning how often, how frequently do we see it. This is based on the study we are doing in Frankfurt, or we have done in Frankfurt. It's a review we did in Frankfurt on current literature. And we found quite interestingly that early studies, the pre-2012 studies, did show a fairly low peri-implantitis rate, 8%. Some studies talk about 5%, so this is fairly low. However, if you look in more recent studies, certainly these numbers are jumping up quite critically. So the trend is that we see more and more peri-implantitis, probably due to that we're looking closer and we're finding peri-implantitis earlier than we did in the past. Some Brazilian studies in actual fact report peri-implantitis as high in the 70% peri-implant disease, which would be very, very high. Again, these are Brazilian studies that might be the cohort in Brazil. I don't know why the numbers are so high, but that contributes to a fairly high peri-implantitis prevalence. The link between bleeding and proving a peri-implantitis due to these findings is a bit disputed again at the moment. Suppuration, yes. Bleeding is probably more linked to peri-implant disease, not always peri-implantitis. However, it is still defined in the definition till to date. So we looked into the literature. I want to spend a few minutes on this. We looked in predisposition to peri-implantitis, and we looked at the literature and had a little bit of look around to see what sort of factors people were thinking of might contribute to predisposition to peri-implantitis. The obvious factors came up, like smoking, periodontal disease, gene polymorphism. That's a little bit a newer idea. That's age and gender was discussed quite frequently. The lack of oral hygiene treatments, or the lack of oral hygiene and plaque status in general. Diabetes has been discussed as a predisposition factor. Hepatitis has been discussed. Thyroid disease, and so on. And even the body mass index has been discussed as a potential predisposition factor to peri-implantitis. Probably mainly due to BMI seems to be a factor for periodontitis. Quite surprisingly, if you looked at the results we had when we looked close into the studies, is that none of these factors was convincing. So even periodontitis did not convincingly show up as a predisposition factor. That was quite surprising, we found. Current periodontitis, or the history of periodontitis, again, was not a strong predisposition factor to peri-implantitis. I will touch that later and explain why. That was an interesting finding as well. Here we go. We looked a bit further why that was, and Faveri and Deptout found two publications where they looked into the biofilm of peri-implantitis, and at the end of the day, they found that peri-implantitis, despite looking like periodontitis, is not the same biofilm. So we have a totally different disease here. Peri-implantitis is not periodontitis. There's no correlation, or very, very weak correlation. Both inflammatory, that's that's about it. However, gene polymorphism is discussed more and more in literature, and there were a couple of studies where they combined gene polymorphism and smoking. And when we look at these factors combined, they were predisposing factors to peri-implantitis. This is pointing towards a new look at peri-implantitis. It's probably not single factorial, but multifactorial. Would be interesting to see if smoking combined with hepatitis, smoking combined with diabetes would create a predisposition. So far, there are no studies out there having looked at it, so that's very new territory. But we know that in certain genetic types, smoking is a predisposition factor for peri-implantitis. Again, that's our study in Frankfurt. So obviously, I'd like to dwell a bit on it. Okay, so we have cleared now that what peri-implantitis is. We know what the diagnosis is. We know where we don't know quite where it's coming from, but we know how to diagnose it. And let's look into treatment options at this stage. Let's move on. Treatment options, classically, you can talk about non-surgical and surgical treatment options. I want to quickly touch on the non-surgical techniques. I don't go into detail there because the non-surgical techniques are not that relevant. It's all about removing of supra and subgingival biofilm, so no rocket science behind that. The subgingival biofilm can be difficult to remove on implants with peri-implantitis, as the implant threads are quite often not covered by bone anymore, so your hygienist will really struggle getting them clean, and that is the limitation of the non-surgical technique. You just can't clean it very effectively. But essentially, what we have available is scaling, antibacterial agents like chlorhexidine rinses. Again, they probably don't reach the depth of the pockets where they have to go. Irving Beck lasers and chlorhexidine in combination are discussed more frequently nowadays. Again, with very mixed results. Probably the shadowing on the laser is the problem. Laser just can't reach all the surfaces. And antibiotic therapy has been discussed quite in depth, again with very mixed results. For scaling, obviously you can use hand instruments or ultrasonic instruments. There's no rocket science behind this. However, there is no real significant advantage of an ultrasonic instrument over a hand instrument. They're both quite inefficient. We can obviously inject some antibiotics into the sulcus, into the pocket around the implant. This seems to improve the therapy slightly, but the data is quite limited, so we don't know much about it at this stage. Generally, it is recommended, or generally all authors recommend the non-surgical treatment in cases with very limited bone loss. So the non-surgical treatment is really more for the peri-mucositis, for the peri-implant disease, not so much for the peri-implantitis. So let's move on to the surgical options. So our surgical techniques we have available for peri-implantitis. Again, very simple, two groups. We have the resective therapy, which could be a gingivectomy, quite simple. We reduce the pocket depth by using gingivectomy, or the implantoplasty. Implantoplasty is a word or a term which was first used by Frank Schwarz in Düsseldorf. He is at the University in Düsseldorf, which describes the polishing of the exposed implant surface. So we polish the implant surface. He called it implantoplasty, one of the resective therapy options. And then you have regenerative therapy options, obviously, which is a GBR. So there's nothing really new. We can try to rebuild the bone which has been lost. And we have soft tissue grafting. Interesting enough, I think the soft tissue grafting is the more relevant regenerative therapy. I do GBR on peri-implantitis affected implants, but I generally speaking combine this with a soft tissue grafting, as I think the soft tissue is a more relevant tissue to protect these implants. So when do we use surgical options? Essentially, these are my criteria. I want to see an advanced bone loss, so a bone loss of over 3 millimeters. I would certainly consider surgical options. And in implants with a persistent clinical presentation. So if you see a patient and you do a non-surgical approach and it's just not getting better, obviously you want to step it up to a surgical approach. So let's look a little bit closer into the resective techniques. Purely resective techniques, essentially, if we have a suprabony defect or vestibular dehiscence, I would not choose a regenerative approach. So this is a purely resective approach. I basically just aim to reduce the pocket depth and create a more adequate soft tissue condition and to facilitate oral hygiene. So I want to make it easy for my hygienist to clean that implant surface. So it's a purely resective technique. Jenny speaking. Oh, sorry, I went too far. Oh, I'm struggling. Sorry for that. I have to find my. Here we go. Jenny speaking, when I do a resective treatment on an implant, so I don't plan to regraft, I will combine this with an implantoplasty, as Romeo and Al have shown. If we combine the resective treatment with the implantoplasty, it is much more successful. I will show a couple of cases very soon now where we did resective treatment with implantoplasty, and it becomes quite evident why it's more successful, why it's easier to maintain afterwards. When we do regenerative therapy, obviously we have to think about how do we graft on these implants. There were a couple of studies done by Schwartz as well as Mombelli. They looked into bio-os and similar xenografts. All of them seem to work quite well. So Schwartz concluded bio-os is better, but I would say they all work fairly comparable as a graft material. I would not use any other graft material. I wanted something really, really stable, and we know bio-os and similar xenografts stay there for a long time and give us a really stable base. We jumped this, we don't need that part here. Sorry for that, otherwise we're running out of time. Summarizing, when I think about peri-implantitis treatment, I'm interested in the defect topography to decide what sort of surgical therapy I want to choose. I'm interested in the implant surface because that again has an impact on how I will treat that implant. I will show a few surfaces very soon, so you can have a look at it. It becomes quite evident once you look at the surfaces why we treat them the way we treat them. I looked at soft tissue thickness and condition. So what type of biotype do we have? What is the condition of the soft tissue? As I believe soft tissue is the key to keeping that implant healthy. Obviously, we have to look at the cosmetic considerations, particularly resective therapy. It looks bloody awful afterwards, to be frank. You have to warn the patient. And we look into patient cooperation. If you think the peri-implantitis is due to a lack of maintenance, because the patient did a lack of maintenance, I'm certainly not too keen on starting peri-implantitis treatment, as it's bound to fail. There's one more thing, there's one novel approach, and that's the approach for the University of Frankfurt. It's a proprietary process, so I don't have any slides of it, I can't show you anything. I'm don't know when it will be published, but they use iodine electrophoresis to clean the implant surface. That's a novel approach, but I haven't seen any publication yet. I've seen a prototype, but that's about it. So watch that space. Something might come very soon from the University of Frankfurt. It will be no doubt very expensive equipment you can buy for that. If it's the answer, I don't know. We will have to see. Okay, so at that point we have covered the diagnosis of peri-implantitis. We know how it looks like. We covered a little bit the decision tree, when to do surgery, and what sort of surgery to choose. And I will now run it for a few cases to show my decision tree and why I do what I do when I do it. So we have the first case here. We have two regenerative cases and two resective cases in this presentation. That's the first regenerative case. You've seen that X-ray in the beginning. Typical defect. Let's call it peri-implantitis because I think it is peri-implantitis. For this particular implant, I think I know why it has happened, what has happened. This is obviously a sinus lifted implant. We see the sinus graft up here. The implant has an SBA SLA surface. So it's a tree implant. So SLA is the Straumann equivalent. SBA is the tree equivalent, but that's how the surface looks like. So it's a moderate rough surface. It's not a super rough, it's moderate rough. This is the implant at time of placement. So we have our implant here. We have our lateral window for the sinus lift here. And I was a bit sort of rough with the membrane, Schneiderian membrane, and I ripped the Schneiderian membrane. So that was not a good day in the office this particular morning. I stitched that membrane back up, so I sutured the membrane. But to suture this membrane down there takes a lot of time and is very, very difficult. And my presumption is a presumption at this stage, because it was a very difficult thing to suture, and my nurse wanted to help me, she wanted to be nice to me. She kept this really, really dry, so really free of blood, which in turn most likely caused bone trauma. So when we uncovered the implant, this is what we found. So this is a typical presentation of peri-implantitis now. We have a bowl-shaped defect right around the implant. The implant is stable, so there's no mobility in the implant, and we have a nice high bone peak here. We have a reasonable high bone peak here. We have palatal bone, and we have buccal bone, which is very, very thick, so it's sort of more crater. You see, it's an old tree implant. There is no polished collar. The collar is still a rough collar. They are not available anymore for quite a few years. So what did I do? I cleaned the implant. I used a magic solution to clean the implant. It's called saline. So we wiped that implant nice and clean. I attached a membrane. I fixed the membrane with a membrane nail here. There's some BIOS underneath or MP3 underneath. I can't remember which graft material we used. We can't see that here, unfortunately. We had nice closure of the grafted side. This is important to have it really well closed, otherwise your graft ain't gonna work. Here's the X-ray of the graft. So you see the implant sitting over here. We see the volume of graft material here. Over here, this is the little pin securing the membrane. I used only one pin. I quite often only use one pin. I know some colleagues use two pins. I keep it mostly to one pin. And this is the same implant 4 months later at time of prosthesis, of attachment of the prosthesis. This is the new prosthesis attached to the implant. Here's our implant. The nail is still there. The bone graft has dropped a little bit. This was expected. I didn't expect to get bone right to the implant shoulder, but we have a vastly improved bone scenario around this implant. So the graft has worked. This is the case beforehand. And now that's where we are. And this is a 3-year follow-up now. So 3 years later, another X-ray, and we don't see a change in bony contour. So this is a successful peri-implantitis graft. This is the clinical photo of the tooth. Unfortunately, we didn't regain papilla, but this was somehow expected that we probably won't get the papilla back. Another case, this is an older implant. This is an external hex Brennemark implant, so that's quite old. Here we have our presentation, our clinical presentation. Is inflamed, is angry. After removing the crown, you see how fairly angry that soft tissue is. It's a thick biotype. This is very positive, but the tissue is very, very angry. And right at the uncovery, you see this a similar presentation. It's a bowl-shaped defect around that implant, and we have threads exposed. That case was done quite a few years ago. At that time, we still used tetracycline to treat the implant surface. So that is tetracycline powder in saline. I don't do that nowadays anymore. I don't think it gives us any benefit. By that time, that's what we did. Here we have a graft material. This is bio-os. Fairly large particles. I don't like small particle bio-os. It's fairly large particles. Again, the same thing. A membrane goes over it. I'm fully aware that there are at the moment more and more manufacturers coming up and saying we have a graft material, the magic powder, which does need a membrane. Just sprinkle it on and get bone. I don't believe in that, so I use membranes. So we have a membrane cover here, which is a xenograft, bovine membrane. That's the implant with the graft material at the time of grafting. And this is the implant at time of uncovery. So it was not expected to get bone to up here because this is already the neck of the implant. So we get fairly high bone regenerated around the implant. This is a temporary crown done on the die. It's not the most beautiful looking one, but it does the trick. To do a little bit of soft tissue shaping for 2 or 3 weeks. And this is our result after a couple of weeks of healing. So this is our new soft tissue, very healthy, very stable looking soft tissue. This is the final crown done by the prosthesist. And this is the follow-up photo he sent me after, I think, 5 or 6 years now. With very, very stable soft tissue around that implant. A bit scar tissue here. We couldn't quite avoid that. Close up again. You see there's no inflammation, nothing. This is truly free of inflammation, this implant now. Here the X-ray follow-up. So this was the X-ray before. Here's the X-ray, sorry, this is the X-ray before, and this is the X-ray after. So the bone level is at the first thread, and here we are at the 1, 2, 3, 4th thread. So this is, and mesial, we have bone up here now, where before we are down here with the bone. Okay, these were our 2 regenerative cases. So whenever I can, I try to regenerate the bone because I think it gives us a much more stable long-term outlook. However, as I've shown before, we need the criteria to be right for regeneration. So we need that bowl-shaped defect. We need reasonably good soft tissue. So we need something to work with. However, in some cases, you just don't have this. And then we're coming to the resective cases now. The problem in the resective case is that you get a lot of gingival recession afterwards. So it's a cosmetic nightmare in the front. You have to talk to the patient about that cosmetically. A resective case in a front tooth implant will not look nice. Sometimes we are lucky with a low lip line, we get away. In a high lip line, it obviously becomes an issue. And here's a gentleman, he came to me a few days ago. And I've put that case in here because I found it quite interesting what we found in there, so that's why I put it in. So it's a fairly new case. We just saw the gentleman with fairly inflamed area around this implant. This is the X-ray you remember from the beginning when I said there is sort of a funny area here. Not sure what I'm seeing there. I'm still not sure even after surgery what it is. I will show you later, but I'm just not sure what it is, but there's something there. These implants are Thionite. These are Noble Biocare implants. These are both Replace Select implants. This is how Thionite looks like. A very rough surface. Furthermore, there was a tendency of Noble Biocare to apply Thionite right to the implant shoulder. So the Thionite comes really high up. If this becomes exposed to a biofilm, there's no way you can clean that. You can clean that anymore. These are porosities, you can't clean them. And that has an impact on your treatment plan, obviously. If you can't decontaminate the surface, you can't graft. So we removed the prosthesis, and that's what we saw here. That looks sort of not right. That shouldn't be there in the first place. I pulled that out with a hemostat, so I have no idea what this is. Can't be cement. This was a screw-retained prosthesis. So your bet is as good as my bet, but there is something. It is something of some sort. After raising the flap, this is the presentation, and you see the defect is much flatter. So there is very little bone peak here. There's very little. There's a bit more bone here, but it's a very flat defect, and palatally there's nothing. So this is a defect which would be very difficult to graft in the first place. Secondly, it's a Thionite surface. It's very difficult to decontaminate. So therefore, the decision was to do an implantoplasty. Here we go. This is how an implantoplasty looks like. Very messy. Can't do anything about it, but you have to polish the threads off. You have to make that thing shiny. And the idea is that you get a surface where the hygienist can actually use the scaler and clean that surface. However, the soft tissue is not very healthy, so you go to the palate. This is a single incision CGT graft, single incision. So there's no relieving incision, it's just a single incision. This is the first molar, so we could have gone even to the second molar. That's the maximum length we can go. When you do these grafts, obviously be aware of the major palatine artery that runs down here somewhere. You don't want to cut through that one. So you get a fairly chunky bit of connective tissue, place this over your implant, and close it up. So there's no graft material on the implant. There's no bios, as it won't work on an implantoplasty surface anyway. And definitely not if it's such a flat defect. In a bowl-shaped defect maybe, but not in a flat defect. And we have a second surgical resective case. Run through this quickly as well. This is a tree implant. There's a new one. I was very unhappy when I saw that. There's a fairly new implant placed. Obviously, it's part of a locator denture. When we opened this up, we found a bit of impression material overpressed. So must have happened when the impressions for the dentures were taken that something was overpressed. Causes a foreign body reaction. We get a peri-implantitis. What we have here is that we have fairly good bone, mesial and distal, but we have lost the vestibular bone. So this is that vestibular dehiscence. So there's no way we can graft this. The graft will just not take to the surface. The site is not really that good for grafting when that happens. It's not a bowl-shaped defect, it's more a dehiscence. Here is it even better. We have bone here, we have bone there, but sort of nothing in here in between. And that's how they look like. So you do an implantoplasty. Obviously, the locator is gold-coated. You remove some of the gold coating. Really difficult to get in here and in here with the polisher, but we just polish it off, make it nice and smooth. Okay, so these were the first 4 clinical cases, 2 regenerative cases, 2 resective cases. I did run through how we diagnose peri-implantitis and how we make a decision what to do with that particular case. I think now it's time to look into preventing peri-implantitis. So that's the part of the peri-implantitis prevention of my presentation. And when I think about preventing peri-implantitis, I think about local factors first and foremost. So do we have cement or foreign bodies around these implants? Obviously, screw retention is my favorite for my dentist. When they refer me implants, I refer them back. I ask them for screw retention. However, sometimes we have to cement retain, unfortunately. But this is the first and foremost. I look at local factors. Do we have cement there? Because this is really a driving factor for peri-implantitis. Secondly, I look into implant considerations, shape and surface, because implant shape and surface might have an impact on peri-implantitis. This is where the tree soft tissue concept might come in very handy, and I will show a few slides discussing the advantages there. But yeah, implant shape and surface, a particular surface, is an issue, so that's one of my considerations. Soft tissue condition, really important. Biotype, really important. In a thick biotype, you get away with everything. Thin biotype, you're losing. Let's look at foreign bodies and peri-implantitis. This is the case a friend from Russia sent me. Obviously, it's peri-implantitis, there's no doubt about it. And we got these two marks here. That is most likely cement. This most likely cement triggered a peri-implantitis. Here's another case. We had to remove this crown. This crown is cemented on, it's not screwed on, so I had to drill a hole for the back to get that crown and abutment off in one piece. So there was no need for that crown to be cemented. But this is a big piece of cement here. It can be very difficult to remove and can be left behind, and it's disastrous for implants. That's the case I showed earlier. There is something here. It is a foreign body of some sort. I don't know what it is, but it is certainly not just dead tissue. This is something. And it was inside the implant interface. I have no idea how that got there. So it's a foreign body, most likely. Systematic review here. Fairly new, fairly recent. They looked into biological complications again, and the conclusion was, yes, cement is the #1 biological complication in implants with peri-implantitis. Zinc oxide eugenol cement seem to be better, but they are still not the solution. Obviously now someone could say, well, listen, we do custom abutments, you got CAD-CAM abutments nowadays, we don't have that problem anymore, we can clean them really, really easy. Unfortunately, this is not really true. Recent study here from 2016, even CAD-CAM abutments do not guarantee that we get the cement out. So in case a crown needs to be cemented, this is what I say to my referrers, please use a cementation post. Cementation post is nothing else than a copy of the abutment. Your technician can provide this. You fill your crown up with cement, you stick it on the post, you clean it up, you pull the post out again, and then you stick your crown to your implant abutment. By doing this, you greatly reduce the risk of cement. Stable soft tissue. That's another story. We looked at soft tissue condition. This is what we want to prevent peri-implantitis. This is a tree implant, and this is our keratinized tissue, what we have around that implant. Obviously, the hole at the moment, that's after removing for the healing abutment, is perfectly round. I want it oval shaped. I'm at the moment discussing with tree to get some two-piece healing abutments made up, which are oval in shape. But nevertheless, we create very nice, healthy keratinized gingiva around this. And this is what Mr. Kast talked about earlier. The tri-tissue concept is this curvature here, this continuous emergence profile. And what it does, it allows more thickness in the soft tissue. We have a thicker band of soft tissue surrounding this implant. But foremost, if you look at a round emergence profile versus a straight one, this line is much longer. So we get a longer attachment just physically the attachment within the soft tissue and the abutment is longer and therefore better sealing. So this in itself, I would say, is an advantage to prevent peri-implantitis. Again, a case I saw yesterday, that's brand new. We saw that lady yesterday, she was referred to me. This is an implant crown over here, obviously. And there is something happening with the soft tissue here. It's not peri-implantitis, but there is a soft tissue dehiscence, and we see the bottom of the crown. And if you look at that soft tissue, it's extremely thin. She's a very, very thin biotype, very delicate tissue. So this will develop into peri-implantitis sooner or later. So we open this up, and the first look is, oh holy, that implant sits somewhere out here. However, when looking close on it, it is actually covered more or less by bone. It's just very, very thin bone. The bone was not wide enough for the implant placement there, or the bone graft did not work. So this is not a dehiscence of bone yet. This is not peri-implantitis, but the soft tissue is far too thin to stay stable in the long term. So we decided to do a CTG, a connective tissue graft from the palate, a CTG, to improve that soft tissue quality here. And again, technique is fairly simple. It's a single incision technique. We go to the palate again. This is 7, so we could, in theory, go right to there. We don't need that much. This is sufficient amount of soft tissue. We get our connective tissue graft, quite chunky bit of connective tissue. She had a very thick palate, which was very nice. And we insert this over the implant. So we prepare a pouch here. You prepare a pouch on the other side, and with a horizontal matrix suture, you pull that graft underneath the edges. You want the graft really underneath the soft tissue edges, otherwise you don't get blood supply to your graft. And we close the whole thing up. So see, we're already running 45 minutes, so we're running a bit out of time. I'm sorry for that. Let's get to the final slides. Implant surface consideration. This is something again which I'm really interested in. So what implant surface do we have? So how do different implant surfaces look, and what consequence will that have? So they have thionite. I showed that earlier. Very porous surface. So if you get any exposure to a biofilm, you will struggle. You have a real problem here. In actual fact, we have some colleagues here in New Zealand who are not talking about peri-implantitis. They would talk about thionite nowadays, because they have seen so many problems with thionite, particular in implants, probably placed 6-7 years ago, as Nobel Biocare applied the thionite right up the whole implant. The idea was that rougher surface would facilitate soft tissue attachment. The problem is, if you get any dehiscence, you get peri-implantitis, and you can't control that very well. You have to remove the surface, and then you can't graft very well anymore. Then you have trabecular metal or and endopore. Both are similar products, I believe. On the left, it's trabecular metal. On the right is endopore. This is even worse. So if you get any exposure of these surfaces to any sort of biofilm, your implant is pretty much gone. So not a surface I would therefore consider for an implant as a long-term surface. And then there's the SBA, SLA surface. SLA is the older word for it. It comes from Straumann. SBA is identical to SLA. I think there's just some copyright, some commercial patents why it can't be called SLA again. But it's the same surface. It's an acid washed surface. They are moderately rough, and hence my preferred surface in terms of keeping this peri-implantitis free. There were a couple of studies done which showed that the SBA SLA surface does demonstrate the best balance between the speed of osseointegration and the risk of peri-implantitis. So essentially what this means is the rougher the surface, the quicker it heals in, but the higher the risk of peri-implantitis. So you have a sweet spot somewhere, and the SBA, SLA surface is that sweet spot where we have a good balance between osseointegration and reduced risk of peri-implantitis. Okay, that brings me to pretty much to the end of the presentation here. I've got a little video here. I'm not sure if that will play, if you can hear the sound. I just started up. Let's see if that works. Would be nice. This is a project a friend of mine has started, a friend of mine from Russia. Damir has started that project. It's based around the idea that it's really hard to get a mentor or get reliable advice from the internet. Obviously, everyone can post on Facebook whatever they want. So essentially, it's a sort of a closed website where you can log on and you can subscribe to a mentor and can basically scratch his or her brains to help you with managing your implant cases. So if you're interested, have a look at the website. It's very new. It's in progress of being built at the moment, so it's not completely functional, I believe, yet, but it will be functional very, very soon. So have a look at www.mentormedental.com if you're interested, and you can subscribe to any of us as a mentor to help you in your daily practice with any questions you might have. Okay, dokie. This is again Auckland, city of sales. So quite a few yards in front of it. And if you're a sailor, then you know that we won the America's Cup again. So we bring the cup back to Auckland where it belongs to. And yeah, I would like to say goodbye from Auckland. It's time to go to bed over here now. It's close to midnight. Depending where you are, you probably have your lunch break or you're about to start your working day. So in that case, enjoy your day. And my email is down there, so if you have any questions, just flick me an email and I'm happy to answer them. Thank you very much.
Thank you, Dr. Blaschke. Thank you for this nice presentation. I would like to tell the audience, if you have questions right now, please type them in the question field in your toolbar on the right side. You can type in questions, and I am going to moderate them directly to Dr. Blaschke, and if not, you can use his email address, or even of the TRI email address. You can send your questions, and we're going to answer them. There's one question of Dr. Amor Al-Hunaiti. I think it was a question to the case 2 regenerative case. He wanted to ask, or he wanted to know, in case of regeneration, how long do you wait to reload the implant after you treated it?
Well, the implant itself is stable. The implant is still very well integrated, so you can load them fairly soon. I would say you need good soft tissue healing. You need a bit of stability in your graft. I would say maximum 3 months. You can quite often probably even go in after 1 month already, because implant mobility is not the issue. Implant loading is not the issue there.
Okay. Now they are popping in a lot more questions. Give me a second. I'm going to check them. There's David Chan. Is hybrid implant with a machine collar a possible answer to the peri-implantitis? What is your option, Dr. David Chan?
What hybrid implant?
Is a hybrid implant with a machined collar a possible answer to the peri-implantitis?
Yeah, the machine collar is an advantage. You still have the risk of peri-implantitis because recession can go past the machine collar. But yeah, machine collars are a good option. All the implants I use nowadays have machine collars again. So I'm away from the rough collars. I don't use them anymore. We are on machine collars now. Yeah. Good question. Okay,
then there's a question from Chadi Maurun. He asked, in case the first case you showed with the TRI implant with the SBA surface, how did you clean the surface before Yeah.
Very good question. There are a couple of suggestions out there. As I said, Frankfurt works on an iodine phosphorases, for example. But I follow the recommendation from of Frank Schwartz in Düsseldorf, and we use the magic solution called saline. It's basically just saline, just a saline wash. That's all what the implant gets. We don't have to do anything else, just saline.
Okay, thank you for answering. Then there's a next question from Cameron Castle. Are there
Hi,
any...
Cameron. How are you going?
Okay, you know each other, nice. Are there any are there any correlations between non-conical connections and peri-implantitis?
Yeah, that's a really hot topic. Obviously, a conical connection, as being an extremely tight connection, has very little in terms of a pump action. So the abutment doesn't move a lot, or has no movement at all anymore. So a conical connection is a very tight connection. Tight connections are preferred in terms of reducing the risk of peri-implantitis. Tree has a friction grip abutment. We haven't tested this, Cameron, but we are talking to Frankfurt at the moment to run a test series to compare the friction grip of the abutment to a conical implant connection. My gut feeling says they're acting very similar because they're both very tight connectors.
Yes.
But you're absolutely right. I would prefer a tight connection over like a tri-lobe. Tri-lobes are very, very loose connections. I don't like them at all. So yeah, conical or internal tapered abutment is the preferred abutment.
Yeah, and, from my point of view, the friction connection leads to no movement between abutment and implant. So you have no movement and no widening out and micro gap or not. So this is a very good solution from my point of view as well. So that's one more.
I think we have seen the same, yeah.
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 So Ahmed Heikel, he's asking, what is your opinion about sticky bone in the treatment of bone defects due to peri-implantitis?
Sticky bone, yeah. Okay. How do I say that nicely? I'm a little bit concerned about some claims what we see in terms of CGF, PRP, APRP coming out from the industry at the moment. There are a lot of sort of growth factor claims. So far, I have not seen any well-done research. I haven't seen any well-done reviews if these growth factors in actual fact have any impact on the bone whatsoever. My personal opinion is these growth factors, which are in the sticky bone, are derived from venous blood, and this is free of any BMPs. So we only have growth factors of the fibrin cascade there, which might help with soft tissue healing, but I don't think they have any positive effect on bone healing at all. So I don't use sticky bone, and I get exactly the same results than people using sticky bone.
Very good. One last question, and the rest we're going to answer afterwards. From Sirach Samuel. Can we consider laser to be the best method for disinfection of the surface of this disease-infected fixture?
Yeah, sure. Unfortunately not. Lasers have a real problem in terms of shadowing. And if you look at the geometry of an implant, there is a lot of shadowing happening. So laser I don't think is the answer. The same as these little brushes that you can buy, they're not the answer either. They can't get in there either. So if we have a surface with what we cannot decontaminate by wiping clean, like a Thionite surface, we have to remove the surface with the burr. This is the only way to get the contaminants out. Unfortunately, once you do this, you can't graft to the surface anymore. It's very difficult to graft to the surface afterwards.
Okay, I would say all the other questions we're going to answer afterwards. We have all the questions already here, and we pass them to you, Dr. Blaschke.
Brilliant. Yeah.
And I would like to say thank you very much for this topic, which is not the most fashion topic in implantology, I guess. And I think it's not easy to do a presentation which is based on interests, and it's not so easy, and it was very great and very interesting. Thank you very much for this, and I would like to take the chance to give you some more information about the upcoming courses of GRI dental implants. Thank you, Dr. Blaschke.
Thank you.
So give me the chance to just
if I can quickly interrupt you, Holger. Sirin from Sydney has mentioned that there is a cadaver course coming up in Sydney.
Okay.
For the Australian colleagues, that might be interesting. So it's a fresh cadaver course which is planned.
Yeah, if you want to know more about this course, please contact us as well. Yeah. I would like to give this information that there is 2 times an advanced course of all-on-3, which is all-on-4 technique upcoming. There's a few seats left in September, from the 14th to 15th September in Porto. And then with Dr. Luis Bessa. And also with Dr. Luis Bessa, there is one last all-on-4 course, all-on-GRI, all-on-3 course in December in beautiful Zurich, which includes a production visit. So feel free to contact us to be a part of this course. And then there is 2 last courses in November with Dr. Mario Steigmann about soft tissue management. One is from the 2nd to the 3rd November. There's also a few seats left, and as I know, there's also a 4-day course, 13th to 18th November, where we have also some seats left with Dr. Mario Steigmann in Heidelberg, in his institute, in the Steigmann Institute. And then a very interesting course as well in Zurich will take place in November 23 to 25 in the university in Zurich with Professor Hammerle and Professor Dr. Ronald Jung from the university in Zurich, which is a very, very interesting course, a 2-day course. And if you are interested, please contact us directly. So then there is always a next webinar. The next webinar, which I like very much because I'm a dental technician myself, is going to be with a friend of mine, Vani Kaufmann. Vani Kaufmann is a dental master technician in Switzerland, and we're going to have the topic 3D printing, which is a big topic always more. The digital workflow in the industry is getting more and more important, and at the ARO in October in Madrid, we're going to launch a lot of really interesting products about which you can use in the digital daily workflow. And so we have the topic 3D printing in the dentistry. So this is going to take place on the 27th September as usual at 12 Central European time. And then I'm very proud to give you this information. This is the first time we give this information. We're planning our 3 World Congress in Ibiza from the 4th to the 5th May 2018. So if you are interested, please contact us, and if you want to be updated of our newest products and of our next education trainings and so on, please just get a member of in Facebook, so you can be updated. And so then it's also from my side to say thank you again, Dr. Blaschke. Thank you to listen to this interesting webinar, and see you soon. And if you have questions, please academy@3implants Swiss. Thank you and goodbye.